So topic for discussion is management of burns. One question, you have heard talk on ARDS. What is the link between ARDS and burns? So it is one of the cause for ARDS. Burns is cause because it is extrapulmonary ARDS. Okay. Before going into details of the topic, this is the statistics. See number of deaths because of burns. I have data up to 2019, and it is fourth common cause of death. Non-fatal burn injuries are leading cause of morbidity, and most important thing is it is preventable. Okay. Now we'll start with one case. Here is 40-year-old male patient who presented with alleged history of flame burns secondary to cylinder blast. And he was taken to a local hospital, and after the initial fluid resuscitation, he was referred to a hospital with specialized burn center. So for your information, there are only two hospitals which admit these type of patients. One is St. John's and one is Victoria. When you want to manage these patients, there are certain key aspects. These are the aspects I'm going to discuss. Fluid therapy is most important when you are dealing with patients of burns. As the percentage of burns is increasing, more than 15 to 20%, fluid therapy becomes very crucial. And there are various methods or formulas which are available. And Parkland is the well-known formula which we are routinely using. So do you want to continue with use of Parkland formula, or is there any change? So if you look at this was invented in 1968. It's quite a lot of a number of years have gone. And any formula, if you see, same thing holds true. Like if you want to manage patients of sepsis, there is a formula of 30 ml per kg. So whenever there is a fixed amount of fluid which is advised, you have to think, is it applicable to all the age groups? Whether I am taking into account comorbid illness this patient is having. So there is no change in the formula if you look at extremes of age or comorbidities. This is only a guideline. This will tell you, please start fluid resuscitation and monitor the parameters such as urine output. That will give you a better idea whether your fluid resuscitation is adequate or not. What are the endpoints for fluid resuscitation? When you treat patients of sepsis, you look at base excess or lactate. Same thing you can use in patients of burns. And the target urine output is 0.5 to 1 ml per kg per hour. So if you are able to achieve that target, probably you are resuscitating patient very well. This term you would have come across. What is the meaning of fluid creep? When the amount of fluid which is given in excess. And what happens because of that? There is an increase in input to output ratio, and as a result, there are harmful effects of fluid. In patients of burns, there is a capillary leak. So same thing you can see in patients of tropical illness, where you want to maintain MAP, you are giving fluid, but the amount of fluid which is remaining in intravascular space is not much. And this capillary leak is there up to 8 to 24 hours. And which fluid to choose in that situation? So probably crystalloids is the first choice of fluid in these type of patients. And once the capillary leak stops, probably you think about colloids. This is a Starling equation which tells you the reason for development of edema, and this is a filtration fraction which is nothing but the difference between the hydrostatic and oncotic pressure. Then there is a debate about, can I use colloids or crystalloids? The routine teaching is, if I want to give 500 ml of colloids, probably the requirement of crystalloid is 1.5. So 1:3 is the ratio. This is only in theory. When you start treating the patients, there is not much difference. If you look at the studies which looked at difference between colloids and crystalloids, like SAFE study or albumin study, the ratio was 1:1.2. It was not 1:3. So think about it, whether really colloid is going to be beneficial. And there is a modification of Starling's equation, that is modified Starling equation, which tells you that there is a problem in the endothelium. When there is endothelium dysfunction, the glycocalyx is damaged. As a result, your crystalloids and colloids are going to behave similarly. So keep it in mind. So this is what happens when endothelium is damaged, and colloid is also going to enter in the interstitial space. Coming to albumin, the journey of albumin from rescue to replacement. So initially, this 1998 review told us that it is harmful to use albumin. SAFE trial told that you can use either albumin or saline. And there is a subgroup analysis in patients of sepsis which showed that probably there is benefit of use of albumin. But this was not confirmed in a subsequent studies. Looking at the meta-analysis, this is a recent one. So if you want to ask the question, what is its extrapolation in patients of burns? So I'll show you one meta-analysis. This is meta-analysis including only 4 studies. So based on 4 studies, how you can change your practice. Does it really changing the primary outcome of mortality? Probably not. It only ensures that amount of fluid required to resuscitate was lesser, okay, with respect to albumin. There is no mortality benefit. There is no study till now which has shown mortality benefit with use of albumin. So albumin supplementation for hypoalbuminemia, it is unnecessary and costly. And maintaining normal albumin is not going to ensure that patient is having lesser mortality. So think about especially amount of the cost involved when you choose albumin as a resuscitation fluid. This was about how to give fluids in patients of burns. And this is based on the formula. So percentage of burns, if you determine percentage of burns correctly, probably you're ensuring I am giving adequate amount of fluids. If your calculation or prediction of percentage is wrong, what can happen? It can cause hypervolemia or hypovolemia. So these are the various rules you can use. And this is a Lund and Broader chart, which is in practice. Rule of 9 is not in practice, okay? So advantage of this is it takes into account age of the patient and the head circumference or percentage of head area involved is changing with respect to age. Okay, so that is the advantage of using Lund and Broader chart. When you treat the patient of or any patient of hypovolemia or shock, please keep it in mind that oliguria is not always because of hypovolemia. When there is a drop in urine output, probably there is renal congestion and probably patient is going to develop intra-abdominal hypertension. So don't think that patient is having low output, I have to give fluids. No, you have to assess and think about renal congestion. Maybe Vexus score can help you in identifying whether I'm dealing with intra-abdominal hypertension. This may be one of the early signs of intra-abdominal hypertension. The next and most important thing is airway management. How you manage airway in patients of burns. It is, unless proved otherwise, it is a difficult airway. And when the percentage of burns is increasing, what happens? When the percentage of burns is increasing, patient is in hypercatabolic state, and there is an increase in metabolism at the tissue level. Patient is having increase in CO2 level. And how patient overcome this? By tachypnea. So when you notice that patient is tachypnic, don't use NIV. Probably this is the time to act and intubate the patient. Similarly, patient is having hoarseness of voice. Don't give steroid and think that patient is going to recover. Probably not. As more and more you delay, it becomes more difficult to intubate these patients. This article gives you what are the various methods or techniques you can use when you deal with patients of burns. Even if it gives extensive list, you have to think which technique I'm comfortable with and whether I have available experts in taking care of these patients. Okay, so probably inhale anesthetics. So use of inhale anesthetic agents is one of the method you can try, because there you are avoiding muscle relaxants. When you are dealing with airway, please call plastic surgeon, because if there is a contracture or involvement of neck, you have to go for hysterotomy so that the intubation becomes easier. Okay, so these are the various techniques you can use. Then oxygen saturation. So there is a catch here. If patient has increased levels of carboxyhemoglobin, you have to do ABG analysis. That will give you co-oximetry reading and amount of carboxyhemoglobin patient is having. And that will change your management. Now, breathing and ventilation, you have to ensure that patient is getting adequately ventilated. If burns is involving chest area, you have to go for early hysterotomy so that you are ensuring adequate ventilation. Okay, so this is one of the indication for earlier intervention. Circulation, I have already discussed about fluid, so this is nothing but the part of circulation. Coming to nutrition, there are various guidelines which tells you that I can use 25 to 30 kilocalorie per kg per day, proteins 1.5 to 2 kg per kg per day. So there are various equations, Harris-Benedict's or Carreri equation or indirect calorimetry. The easiest thing to use is Harris-Benedict equation, and based on that you have to add stress factor because there is additional component in case of patients of burns. Coming to use of additional supplementation of glutamine. So what evidence tells you about use of glutamine in patients? Redox trial has not shown any benefit with use of glutamine. This was recommendation in 2019 guidelines. It showed some evidence that use of glutamine may be beneficial. Is it applicable in today's world? No. You have to look for recent evidence. So this was the meta-analysis which gave probably a clue that use of glutamine in patients of burns could be useful. And look at here, what you are seeing is number of patients are very small, 56 patients in 2 groups, and that has shown that probably use of glutamine is beneficial. Then researchers have done study especially in patients of burns. So this is the re-energized trial which was published in 2022, which looked at use of glutamine. Is it useful? So none of the outcomes, primary as well as secondary outcomes, were not different in 2 groups. So glutamine has not shown to be beneficial in patients of burn. So you have to note it down. There is no indication for glutamine. Coming to degrees of burns, why it is important? So first I'll just tell you about how we classify degrees of burns. When there is involvement of epidermis, it is first degree burns. When there is involvement of epidermis and dermis, but the nerve endings are intact, that is your second degree burn, where patient is going to have pain. Third degree burn, where nerve endings are disrupted. As a result, there is no pain, but the extent of injury is quite a bit. Fourth degree burns, where involvement of muscles and tendon is there. So it is a quite deep wound. So what is the importance? This is because your surgical management is going to depend on degree of burns. So how you treat surgically these patients? Early intervention, as early as possible. If there is dead necrotic tissue, you have to remove that. Use of debridement. Carpal tunnel release, especially if it is involving extremities. If it is involving hand, you have to go for this. When you start resuscitating, look for development of compartment syndrome. Look for perfusion of the extremities. This is an indication for fasciotomy if you are finding that. And other management is skin is it is preventing infection. It is acting as a barrier to preventing infection, to prevent infection. So you have to cover the skin with what? You can use temporary skin cover like use of allograft or cadaveric skin can be used. And subsequently, you have to go for autograft. Okay, so this is the management with respect to surgery. There are 2 types of excision, tangential excision and facial excision. When the degree of burns is quite deep, you have to go for facial excision. If it is superficial, you can go for tangential excision. Coming to infection. So infection, when skin is lost, patient is prone to development of infection. There is very high risk. How you can diagnose? Whenever patient is having any signs of new organ failure, same like sepsis, new organ failure, look at the source of infection. So it is the wound you have to look at. Okay. So how patient can manifest? Patient can have shock, hypoxia, renal failure or coagulopathy. So these are the signs where you have to think that, okay, patient is getting infection. The predominant pathogens are gram-positive bacteria, Staph aureus, Staph epidermidis, or Enterococcus. As the degree of burns is more, what happens is the patient will require prolonged hospitalization. As a result, there is an increased risk of nosocomial infection. And the organism will be similar to other patients like Acinetobacter, Klebsiella, or maybe fungal infection or reactivation. Like sometimes you may come across viral infection or reactivation of CMV. Okay. So how you can diagnose? Don't send wound swabs. That is not going to tell you that patient is having this type of infection. No, you have to take the biopsy. Tissue biopsy is the recommended sample for diagnosing infection. Then coming to pain control, this is almost ignored, or we think that patient is not complaining of pain. Probably there is no pain. Unless you objectively assess, you won't know whether patient is having pain or not. So these are the guidelines which tell you how you can assess pain in patients of burns. There are various scales. The easiest scale you can use is critical care pain observation score, which takes into account various components like facial expression, whether there is any change in the muscle tension is there, or how patient is compliant with the ventilator. So there are 3 to 4 parameters you can use and objectively assess for the pain. Which medications you can use? You can use opioids or non-opioids. So, and after 1 or 2 weeks, you think that patient is still having pain. So probably it is a neuropathic pain where the treatment changes. You have to use gabapentin. Okay. Use of ketamine, if you use, it can act as opioid sparing, and you can combine these opioid and ketamine because while doing dressing, patient is going to have severe pain. And one thing you may notice that patient is on 10 ml fentanyl and still he is having pain. That is because of development of tachyphylaxis. Okay. So combination of agents is recommended. Coming to psychological support. So think about what happens to the patient. There is anxiety, there is a depression, there is disfigurement, and there may be loss of identity. So patient, once you may think that patient is recovering, but what about psychological aspects? So please pay attention to psychological aspect of the patient. And these patients go, if you involve psychiatrists, probably it will be useful because post-traumatic stress disorder is quite high in this population. Okay. So I tried to cover all the aspects. Few things I have not discussed in detail, like use of vitamin C or how to give blood transfusion in patients of burns. What is the role of beta blockers? So these aspects I have not covered. In summary, fluid therapy is the cornerstone of treatment. General supportive measures like nutrition, infection control, pain control, and glucose target is important. Surgical treatment is important because unless and until you treat the source, patient is not going to improve. And multi-center studies including burns patients are less. Same thing you saw with glutamine. So when the studies are especially including burns are less, how you treat these patients? So can you extrapolate the evidence from general critical care? Probably you can use that as a guide, and that can help you in treating the patient. So if you follow these aspects, it will definitely improve the patient's outcome. Thank you.